How do you screen a baby for ROP when you can't be bedside? Introducing Phoenix Connect, the leading telemedicine platform for ROP screening. Upload exams with images from any wide-field retinal camera and store them in a HIPAA-compliant cloud. An SMS text message or email alerts you when the images are ready for your review. Just click on the link. Access the images from any place at any time from any device. When you're finished, a report will be automatically generated and sent back to the hospital. It's that simple.
Welcome, everybody. Good morning, good afternoon, good evening. We are just starting our second season 12th webinar on telemedicine in ROP. So I can't wait to tell you how distinguished panel of speakers we host today. Before, I have to do some housekeeping announcements. So that's why I am going to share my screen now. Okay. First thing, the audience questions. Web link, Facebook, YouTube channel, type your questions and we will try to answer them live or after the webinar. So as many as possible. Then participation certificate, please contact the program at WSPOS.org and you can receive it. And the Mentimeter questions, which will appear during the webinar, please try to answer them as many as possible. The code for today's webinar is 5722121. And this is the mentimeter.com. And there is also the QR code for it. So, now I would like to present our first speaker. This is, our first member of the panel. This is Matthew Pilblatt. He's assistant professor in Department of Ophthalmology in the University of Pittsburgh. He's the fellowship director of the Children's Hospital in Pittsburgh for, of course, pediatric ophthalmology fellowships. And he has a special interest in ROP screening and treatment and complex adult strabismus cases, as well as he teaches residents surgery. Okay, so our next speaker is Dr. Mangatram Dogra. He's director of retina service at Greville Eye Institute in India. He is a former head of ophthalmology in Advanced Eye Center in Chandigarh, India. He's an internationally recognized expert on ROP and is considered to be a pioneer in this field in India. He has published many papers and peer-reviewed many chapters of books and written them. And he has given a lot of many guest lectures as well. And then I would like to introduce my co-chairman or co-moderator, Dr. Andrea Zin. She comes from Rio, from Brazil. She's I'm sure you know her all over the world. She's an assistant researcher at the Instituto Fernandes Figueira at Rio de Janeiro and head of pediatric ophthalmology department at Instituto Brasileiro de Oftalmologia de Rio de Janeiro, Brazil. She's also the Pan American Society ROP Scientific Committee member, and she's, as you all know, interested in ROP screening and treatment, but also world known for her Zika publications. So I will stop sharing now.
Mansa.
And hand over to Andrea.
You can keep sharing the
sorry.
Thank you. Thank you very much, Mansa, my co-moderator. Next slide. It's a pleasure to be here once more with you. Yes, and I would like to introduce Dr. Mansa Pompei. She's associate professor in ophthalmology at the University Eye Clinic in Ljubljana, Slovenia. Also the head of pediatric ophthalmology department and the World Society of Pediatric Ophthalmology and Strabismus Scientific Bureau member, interested in ROP screening and treatment as well. She was trained at the Karolinska Hospital in Stockholm, Sweden by Agneta Wallin and published many papers in visual retinal development and electrophysiology in prematurely born children with and without ROP. Our next panelist, the next one, is Dr. Polly Quirum. She's a pediatric retinal specialist at Vitreoretinal Surgery in Minneapolis. She's also the director of the ROP service at Minneapolis and St. Paul Children's Hospital, as well as providing telemedicine services to several local hospitals. She is associate professor at the University of Minnesota and has a special interest in ROP screening and treatment, pediatric retina surgery, as well as surgical training of fellows. The next one is Dr. Alejandra Dahuit Mate. She's an associate professor in the ophthalmology department at Necker Enfants Malades University Hospital in Paris. She is specialized in pediatric vitreoretinal surgery, and her major clinical research interests are retinal pediatric diseases and innovative therapies for retinal diseases. Thank you all very much for being here with us. And Alejandra, I think you are our first talking about Panocam and telemedicine. I think you can, yes, you can start sharing, Alejandra.
Thank you, Andrea. I will share here. So thank you very much for this invitation. I'm very happy to be here with you today. And I want to share with you our experience with Panocam in ROP screening and treatment and telemedicine. I have no conflict of interest with this device. As you know, telemedicine is the use of telecommunication to provide clinical health care at a distance. It involves capturing of patient data, usually by non-physicians, for interpretation by a remote expert. Photographic screening using contact wide field cameras can detect treatment and or referral warranty ROP at a rate that is safe and comparable to screening by binocular and direct ophthalmoscopy. And that is even among different camera operators as ophthalmologists, trained ophthalmic photographers, or training neonatal personnel as nurses. Most studies have compared bio besides exams against RedCam, but there is no study that has been performed with Panocam. And that is why I wanted to share with you our experience with this device that we use at Necker Enfants Malades Hospital since 2018. There are two Panocam. The Panocam Pro includes a main unit database with a handpiece that is independent of the main unit and has three interchangeable lenses of 130 degrees, 80 degrees, and a lens for fluorescein and it has an autonomy of 3.5 hours and pictures that have a high quality with true color appearance. We have this device in the operating room. And the second Panocam is the Panocam Solo, and it includes a console and a handpiece that has only one lens that is 130 with, and is also totally portable and has an autonomy of 3.5 hours as well. We have this device in the consultation office. Here are some examples of the picture with Panocam, where you can see the ROP, and some picture in all the quadrants. You can see again the ROP. For us, this is very interesting device because our department of ophthalmology is 300 meters far away from the neonatology department. So with the handpiece, we can just take it and perform the screening here. But also we can perform a screening at the neonatology department of Port Royal, that is 3 kilometers away from our ophthalmological department. And that's why this handpiece that is independent is useful for us. And progressively in France, remote location centers have acquired this Panocam, and we started to work by telemedicine, and we received at least 5 high-quality images for patients to be interpreted here in our ophthalmology department. We think that Panocam has some advantage that are also the advantage of other device and the advantage of telemedicine. Because Panocam provides unequivocal documentation, reducing subjectivity, improve follow-up of patients, and also allows education of parents, but also in training ROP screeners. The independent handpiece allows screening in different sites, and that improves access to healthcare by overcoming geographical challenge, allows immediate communication in the local healthcare and our expert consultants. But Panocam has still some limitation. The most important for me is for dark pigmented fundi that the periphery is seen blue. So the detail cannot be seen. And this is worse, as in this image, when the baby has a small palpebral fissure, because that prevents the adequate contact between the cornea and the camera. And Panocam has a learning curve as the other device, and I will show you some problems that we have with that, and also the cost that is also a concern in some centers, and that is still a problem. So some examples of this dark pigmented fundi where the periphery is blue and the details are not really seen. And this is the occurrence of a retinal hemorrhage during the screening by an in-training screener, and that's because too much pressure of the eye with the Panocam. Hopefully this hemorrhages regressed 1 week after. So in conclusion, Panocam includes an independent handpiece allowing a screening in different sites. Image quality allows detection of treatment and or referral warranted ROP. Panocam is useful for telemedicine in ROP, reduce subjectivity and improve follow-up of patients. However, dark pigmented fundi result in blue periphery that remained a limitation. Thank you for your attention. I will be glad to answer your questions. Thank you.
Thank you for your excellent presentation, Alejandra. I forgot to mention our support to this webinar from Phoenix Technology Group, which produces Phoenix Connect. And this is a telemedicine device for ROP screening. So thank you to Phoenix. And then while Dr. Dogra is preparing his presentation, I can tell you that we have been watching from all over the world. And let me tell you, we are receiving watchers from Egypt, USA, UK, Pakistan, Sweden, France, Slovakia, Russia, India, Malaysia, Chile, Mexico, Denmark, UAE, Jordan, Israel, Lebanon, Kenya, Nigeria, Greece, really global. So please, Dr. Dogra, continue with your presentation.
At the outset, I would like to, I'm audible. Okay. At the outset, I would like to thank Dr. Ken and the team for this invitation. And here, our moderator, Dr. Andrea and Mansa, and all the speakers. This opportunity is great for me to know more people, those who are involved in the ROP work. And I'm going to talk about tele-screening of ROP, especially in our context of middle-income group countries. And this is the work mainly done by Dr. Anand Vinekar. He is very well known for his work all over, and because he was trained with us, and so feel very proud of his achievements. And whatever I present today is basically his work. And I think Alejandra already talked about it, that we have a traditional way of which is still a gold standard. We do binocular indirect ophthalmoscopy, but more and more we are going to the digital screening, and especially in the telemedicine era, where perhaps we'll have, as I'll show you some of those things here, we may have cameras which will be cheaper, which will be more portable, and that's how probably the future would be. And advantages already mentioned again by Alejandra, that we have a objective evaluation, longitudinal comparison, and it's very easy to get a second opinion if you want to have for a particular case from anyone, and evaluating the response to the treatment. And that's something which is really important. And also counseling the parents, guardian, and educational opportunities, especially teaching all your fellows and trainees. And of course, leveraging the trained ophthalmologists for treatment requiring ROP. And one of the problems which has started big way in our country is a medical legal problem. I think for this, we definitely need very good documentation. It helps us in that way. I have just put up here, basically, Anand has put all this in the book. It all started somewhere in Canada by Anna Ellis et al., somewhere in 2000, where they had one rat cam and ROP specialist was doing it. And then in the United States, especially, I think this Stanford group, Sundrop, has been very popular. And here the NICU nurse took all the images. And of course, subsequently, I think already it was mentioned by Alejandra, the EROP by Quinn et al. And this included 9 centers where they had non-physician, this is exactly somewhat similar to Anand's work, and they also evaluated it. And there's also one from Chile, South America, here, where ROP expert took the images. And in Europe, I think this was in Bavaria. And here also, this was basically by the senior resident or the fellow. They took the images. In New Zealand study here, the nurse imaged and as well as graded. I think this is somewhat similar. But the largest number you can see here, which has gone even beyond this images here, is by Anand. And he's developed this KidRap program for the entire state where he works. And these are all trained, you see, technicians, those who would take images, always grade them. And so he has put this, now he started with RedCam, and now I'll talk a little bit about this new RED camera, which is indigenously produced camera in India. So this KidRap program was his baby. And you can see here, he started this for providing this screening in the underserved area, because we have very few people. And what he did was basically he trained these non-physician graders, and on smartphone, because that is available with most people, that is what basically was used. And of course, the way I think this video here is not playing, he took RETCam in a vehicle, and this was taken by all these are the non-physician trained graders. They would send the image by the iPhone here, and the expert would just within few minutes, he'll get the images and give the opinion. And then subsequently he changed it, where it was even the trained grader was also evaluating and trying, and they did very well as far as studies goes with the grading. It is just like this level 1 technician, the images from him you can see, and the level 3, there is a difference. When you train them more, then you get much better image, as well as the quality is very easy to interpret. And I think this was in JAMA, and basically this is the comparison of a EROP, that is the one by Quinn et al. And Kid ROP. And here the turnaround time especially is very important, was between 4 to 20 minutes, because in both it was not done by the ophthalmologist, it was done by trained graders or the trained person who took the images, and the turnaround time was very short. And now this is where he has gone. His images, they have gone into lakhs, 1.5 lakhs almost sessions. He has treated that many babies, entire state is covered. And now at this time, where we started this work in 2008, and of course it's going. And the good part is this has been included in also our national ROP operational guideline by Ministry of Health, Government of India. So they, along with indirect ophthalmoscope, it was his work that the retinal imaging using wide field camera like RETCam by a trained and competent person has also been included, because this is very important. We don't have that many trained ophthalmologists, and we have a program, which is a national program, where we have these technicians which are in the district hospital. They need to be trained for this work. And on top of it, the innovation is required. Why? I'll come to that. We have now this, of course, all of us, we know about RETCam, that has been there for a long time and the only imaging device in the beginning. Now we have this Neo-RET from Forest, India. This is a very small 310, you can carry it in a suitcase. So it is much more portable. So it can be carried to the various NICUs. Even in a week, you can cover quite a few of them. And the cost is also not much. So that's the importance here. You see, the cost is almost, you can say, it will be almost 1/5 or 1/6 of what the RETCam cost. And you get 120-degree view. And I'll just show you the image here. And this is what we had, in fact, evaluated this. We had done evaluation and published this in TVST here. And you can see, I already told you 120-degree and 130-degree. This is the top image from the Neo-RET. And this is from the RETCam. So there was a comparison between both of them, and the image has got a better resolution than what is seen with a RETCam. So here they are also trying to incorporate in a subsequent model angiography, but this is helping because this is more portable. So we were scared of carrying that shuttle to various places. And I think already all over the world, as we are talking here, we are in a situation where I think telemedicine, even in this is from the Australia-based CDC guidelines, it works well. There are pros and cons if we talk of both the things here. Here, cost, that's what I was telling, that cost is coming down. If the cost come down, this has been the biggest problem. I think imaging would be a big thing for us, all of us, and especially in a country like ours, which is vast, and the largest number of premature children are born in our country, in India. And So ophthalmologist-led model is very good, but we have insufficient ROP specialists, very few. So we get a lot of stage 5. That is what is the problem. So we really are looking forward to something like this on a much more scale. So he did calculate the impact of what would be on the economy, and especially I think in 10 states he took, what he did in his own state. And he had almost 160,000 infected will survive, 1,300 will need treatment, and 108 million saved in US dollar would be saved in a year in a blind person. In fact, now we have statistics available for our country. We have something like 20 to 30,000 children for treatment every year, because our premature rate is high as 3.5 million, in fact, at this time, which is calculated. So I think his model needs to be replicated. It is being replicated in more states, and it will be good if we have a affordable camera that it can be done in various other countries. Thank you very much.
Thank you, Dr. Dogra. You gave us very important information about ROP imaging. It's not only imaging, but the program. And I was going to, while I was listening to Alejandra, I was going to ask you, Alejandra, who is acquiring the images? Because it's very interesting. The Panocam, I don't have personal experience with it, but as Dr. Dogra said, the most impact is not the cost of the camera, but also the cost of the professional acquiring the images. So,
of course, Andrea, thank you for the question. Here in France, for the moment, only ophthalmologists are doing these pictures. In some centers are nurses in 2 centers and send me the pictures. But they had been trained for. But most of screeners are ophthalmologists or ophthalmologists in training.
Yeah, thank you very much, because we have a huge audience. We have people from South Africa, from Argentina, in Latin America. We also don't have enough we have a lot of ophthalmologists in Latin America, but not enough ROP trained ophthalmologists. So we are also looking carefully and watching what Anand and Professor Dogra are doing in India, training non-medical personnel. And that's what we are looking for. And thank you again for Phoenix for sponsoring our wonderful webinar. Mansa, would you like to ask?
Yes. I was wondering, because I also don't have any personal experiences with Panocam, but does it use any artificial intelligence in it, or in software like, vessel tortuosity calculation, something that can help untrained, or trained but not ophthalmologists to grade or to decide which pictures to send or not? Alejandra, can you answer?
Yes. No, we are not using that. In fact, we are thinking for the possibility to train optometrists to do pictures. But in France, we think that all pictures should be interpreted by an expert ophthalmologist. So maybe we will go for trainer of the optometrist, but we still keep all the interpretation by the expert ophthalmologist, and we don't have any software for the moment.
Thank you. So I think both so far presented technologies are the greatest advantage of them is the portability, I would say, because 3-nitron neo and also I can see the Panocam are really very useful to transport it from NICU to the NICU, which is also an important thing if you don't have enough money to have a separate machine at every place, right? So yes.
And it's also interesting for the consultation office, because we can follow up patient in the consultation with this camera that we were not usual. We don't do that before, so it's very nice now to have it.
Mm-hmm.
I would like to ask the panelists, if someone who wants to start an ROP telemedicine program, what would be the first steps? Can you all comment on that? You can, Professor Dogra?
Yeah, I think the first step for tele-screening would be you need to acquire one digital camera. That is the first thing. Because if we don't have a digital camera, then we can't go beyond that. So if we have digital camera, after that, you need to train. Maybe in the first go, you have the nurses in the NICU, you can train them. And of course, ophthalmologists themselves should know how to take the images. But the best part is what Anand has shown, that if we train these optometrists or technicians, and they can be trained very well. They take, once they are trained and they are certified, they take better images than what even an ophthalmologist will do, which is going to take images very few times. So that is something which is in the beginning very, very important. And of course, as Alejandra said, I think it's very easy to send these images. Everybody has these phones, and you can send quickly these images even to the expert and get your reply.
Yes, thank you. So we got the question whether we can telescreen with smartphones. So probably yes, right?
Yeah, well, I think at this time, the problem is we can't really image that well, but we do have another device, which in fact is very much used, where they use this camera and put on a small device and take the pictures. But it is a little bit of a difficult situation at this time. And also, I think the light, which is so intense, that can also create a problem at times, which is not so with these contact cameras which we are using.
Yeah, the group in Latin America, they have a lot of experience. Pedro Acevedo and Gabriela Seidman, Guillermo Montealiva, they have a lot of experience screening with smartphones. I would like to hear from Matthew and Polly about implementing a program.
Yeah, so I agree. You need the camera first, and then I'll talk in my talk a little bit about, I think it's really important to have a protocol set up in terms of who's all involved and how these things get done. Because if you start taking photos and start seeing significant ROP, you need to figure out how that's getting treated, and then how does that patient get transferred. So, I think it's a big process, I think, to get a thing started. It's not just getting the camera. There's a whole lot more to just getting the camera. So I think you should have a very thought out protocol with very specific responsibilities on who's getting the images, who's interpreting the images, what happens when there's treatment requiring ROP. And so I think that is, other than you need the camera, so then the equipment, you need camera, someone taking the photos, but then once you have the photos, you need to have the whole plan of what's next.
Yeah. Thank you very much. Would you like to add anything, Polly?
It's the camera. It's having staff that are really committed and well-trained, and people that, we want to be very HIPAA compliant as well in sending these images. And we, are very fortunate to have a very well-trained, committed staff. And as Matt said, just having all these processes along the way so that we know what to do when we do find disease.
So to summarize, the protocol, right, is also important. So machinery, staff, and the protocol. Thank you very much for this warming up of the discussion. So we can please now proceed to Matthew's talk. I would like to thank the panel, and then our next speaker is Dr. Pilblatt, who is going to talk about US perspective on telemedicine in ROP. Please, Matt.
Make sure I'm unmuted. Thank you all very much. I appreciate the invite to this great group. And I just want to give sort of our perspective from Pittsburgh on our telemedicine program, which is not as impressive as the last talk, but we'll give you kind of about workforce problems throughout the world. Even the US has some workforce problems. So, more and more NICUs are popping up in more rural locations. And so if it's more decentralized, it's harder for pediatric ophthalmologists to maybe cover multiple NICUs in multiple locations. In the US, there was a report that 20% of NICUs were having difficulty finding ROP coverage. The NICUs are doing a better job at, 23 weekers and 24 weekers are surviving, and those are the ones highest risk for getting ROP. So more and more babies are going to be getting ROP. And then another paper showed that, a lot of even pediatric ophthalmologists out there aren't comfortable with maybe doing laser. So even the ones we have maybe aren't capable of doing the treatments. And then contract issues, malpractice issues, those are all things that potentially make people want to not get involved. So in Pittsburgh, there's a NICU about 2 hours away that's a level 3 NICU. And by definition in the US, they need to have pediatric ophthalmology coverage for ROP. And so we cover that place through our telemedicine program. I just want to mention the article down below, which if someone's trying to start a ROP program published in 2015 that gives lots of guidelines on the protocol. And so a lot of what I'll talk about today has been taken from that paper. And so again, I just a little quick caveat that this is for the US protocol. Every region within the US and throughout the world, each area is going to have a slightly different protocol and experience. And so each one should set up kind of their own unique protocol depending on their experience. So this is kind of just our protocol in terms of what happens. And so we follow the screening guidelines of APOS on who should get screened. So the NICU will determine what babies need screened and when their first exam should be. They'll get a RETCam photo is what we use. They'll send a secure email. We haven't been using smartphones yet, but a secure email. We interpret that within 24 hours. If we find that the images are inadequate, we'll have them repeat it ideally that same day, if not within 24 hours. And then if they still can't get photos, we'll have that patient transferred. If it's less than what I call transfer warranted ROP, which I'll talk about on the next slide, we'll repeat the images in a week. And so we do weekly images. If it determines it's transfer warranted ROP, that patient should get transferred as soon as possible, although ideally within 48 hours, because our goal is from photos that need treatment that we feel may need treatment to treatment. The guidelines say it should be within 72 hours. And so getting a patient transferred, having them seen in the hospital, setting up treatment, there's lots of logistical issues there. So that should all happen within 72 hours. And then when they get sent home, our protocol has been that they all get at least one in-person exam. So ideally, once they're discharged within 72 hours, we do an in-person exam to confirm there's nothing concerning that was maybe missed on the photos. And so what we've been using is what we call transfer warranted ROP. I know people have used referral warranted ROP or clinically significant ROP to determine when kids need to get sent. So we've used any ROP in zone 1, plus the disease, obviously, stage 3, even if it was outside of zone 1, And then even the kids with stage 2 that start and develop some plus, we send those kids, and then also anyone that you just can't get photos on. And so this is just a patient that we screen. So we'll get the secure email with their, gestational age, weight, their current age, their current weight, and, their medical history problem list. And so we'll take an external photo just to show that, dilation was adequate, make sure there's no anterior segment abnormalities, ideally get a view of the iris, and then at least 5 posterior photos. So posterior pole, superiorly, inferiorly, nasally, temporally. I know the Phoenix system has a nice, it's called the Zone 1 tool, I think, which will actually automatically, you click a couple buttons and it gives you Zone 1. I kind of just manually did it on the left, but just showing that we're, getting out of Zone 1 on those photos. And then for the interpretation, we'll send it back with the patient info, the anterior segment interpretation. And then most of them, it'll often be that I can see the vascularization into Zone 2. I can't see the termination of the vessels. Often we don't get out peripheral enough, but I can say that there's no plus disease and no stage 3 in Zone 1. And so then no transfer warranted ROP, and then we see them weekly. So that would be kind of my typical common interpretation. This is just another kid we're screening. You can see nasally, there's some stage 2 developing. And on the left eye, nasally, there's some stage 1. And I think temporally, maybe there's a little bit of stage 1 as well. And so again, similar interpretation. We'll talk about the anterior segment. Here, I could give more of an interpretation, Zone 2, stage 2, no plus, and Zone 2, stage 1, no plus. And then that kid, we'd see again in a week. So I just did a quick audit of our last year experience. So we screened 26 babies that included 53 exams. These kids tended to be larger babies. So almost 2/3 were greater than 28 weeks and greater than 1,250 grams. So those kids are maybe ideal for the telemedicine in that those are the low risk kids that, ideally doesn't have to get transferred from locally to us. They can get the care locally. And so out of those 53 exams, only 5 did we have to repeat the images because we thought they were inadequate. Ideally that same day, if not the following day. And only 1 kid needed transferred specifically for the ROP. That kid eventually needed treatment, although not right at referral. And then the cost of transferring just that 2 hours is about $5,800. So just the cost savings of the transfer is around $145,000 annually for this small telemedicine program. Advantages include that they just stay closer to the family, local care. When they get discharged, they're going to be following up with their local doctors. So these are all important advantages. And so a couple key points, I think it's important to be able to transfer and get the treatment within 72 hours. So you need time for communication, processing, transportation, a NICU team, and then potentially other logistical issues. We've been recommending at least 1 in-person exam before we terminate the acute phase screening. And then you just need a very good protocol with close collaboration with that outside NICU, and then very specific responsibilities within the protocol to make sure things follow accordingly. And some references. I want to just thank Dr. Mitchell, who's my colleague who helps me with the Tele-Medicine ROP. And I don't know if we'll do questions now or keep going, but I can stop sharing here.
Thank you very much, Matthew, for this very comprehensive. You talked first about the need for coordination, and we could see that on your talk because we need a very well coordinating team to be able to transfer the baby. And I have, first of all, I think I've missed who is acquiring the images.
Good, good question. So it's a nurse practitioner in the NICU. So it's not a, they've been trained to take the photos, but it's not a ophthalmologist or optometrist. It's a nurse practitioner in the NICU.
It's a nurse, because we had an experience here in Brazil training nurses to acquire the images. And then when you transfer the baby to examine, the treatment is needed. The baby is still examined before discharge, before going back to the hospital. Is that right?
So transferring back, it's kind of up to, we don't have a specific protocol for that. You know, if you laser them or inject them and they're doing well, we usually would keep them at least a week or two to make sure that it's responding, there's not skip areas, there's not concerning. So we won't transfer them directly back. But once we're kind of happy that we don't think they need more treatment, we can send them back and then continue the screening. So it's, yeah, we haven't been doing treat and then just send it right back, but make sure that we're happy with the response before we send back.
Now that's very important because transfer is also a risk factor to, you know, for the clinical condition. So making sure everything is fine after treatment, at least laser, because I think Paul is going to give us the anti-VEGF perspective. Thank you very much. We have audience from Italy, from Argentina, Azerbaijan, so we have different healthcare settings, and everyone has to look for what best suits. Mansa, would you like to ask?
Yes, there was an audience question for Matthew. So what is the training protocol for nurses that you use? I mean, how long does it take to teach them to take pictures accurately?
So that's a great question. So there's not like a certificate or a specific program for training to say that, this is a certified technician to be able to take photos. So it's kind of just a hands-on experience trying to teach them, continuing review the photos. So, if you're noticing a lot of inadequate photos, trying to figure out why that is it they need more training, or is it dilations being an issue? So nothing specific other than kind of hands-on teaching initially, and then just continued, auditing the photos. If it seems like the photos keep, are getting worse, then they may need some more additional training, but not a specific protocol or specific training program.
Thank you, Matthew. Andrea, would you like to ask another next question?
Yes, there is another question for Dr. Bioblad. How do you do the single in-person exam after discharge, or do you go into the NICU?
So, for us, we can do it in person, although if you're doing a more remote site, it wouldn't be possible. So it's about a 2-hour trip. So we have them come to Pittsburgh. And so, it works for us because it's not that remote, but that's a problem for other places. So they come to Pittsburgh, we see them, and then a lot of times it's one visit is that they've been looking fine on the telemedicine. We just can't see out into zone 3. They come in, we confirm that it's either mature or they're into zone 3 and they're fine. But it's been in person. We do not travel out to that site. Okay,
thank you. I would like to ask Dr. Dogra and also Alejandra about, do you use non-medical personnel to screen? Is that right, Dr. Dogra?
Yeah, I think only for these digital cameras, they are trained and they would send these images. That is what is being done. And so how it works is most of the time, what we have seen is, I think that is most important. I think even our new camera, the new RET, the treatment warranted ROP will never be missed. That is very important. You see, it may not be that everything would be done. So most of the time, the treatment warranted ROP, because the plus disease will get picked up. And so would be the posterior disease, which is more serious, that get picked up much more. So I think it works very well. Only thing is that we need to have this on a much larger scale. We need to train more people. So that's how perhaps we can save these babies going to stage 5 before they come to us. That is what we are facing a problem at this time.
How do you train those, the non-doctors personnel? Is there a specific training program?
Basically, I think, first of all, as far as the digital camera was concerned, these were trained by the technician, trained by Anand. So they are in multiple places in India now. They would train them. But now, in fact, what has happened, there are now more people trained in every center. So and we have a lot of babies. That is what the advantage is. There are so many babies that even in one day, when we have suppose in our hospital where I was the chairman, when we go for screening, we'll have at least 30 to 40 babies lined up for screening only. So it's very easy where you have a lot of babies and you take pictures for all of them. I think they get trained even within a week very well. So that is what happens.
Thank you. Thank you very much. We all learn from you. And you, Alejandra, I think you mentioned training. Do you use non-doctors?
Hello? Yes, we are training non-doctor. We start recently with the orthoptist, and it's myself that are training orthoptist. The first time is myself that show them how to do, and then is someone that is already training that continue to teach how to do. But at the beginning, it's always me.
Okay, thank you. Mansa?
Yes, so I think we can proceed to our next talk. Our next speaker is Dr. Polly Quiram, and I would like to invite her to give her talk on ROP and telemedicine in the anti-VEGF era. Please, Dr. Quiram.
Thank you, everyone, for inviting me. It's really an honor to be amongst the experts in ROP worldwide. So, we had some great talks about telemedicine, and I want to talk about kind of our approach and how we use telemedicine in anti-VEGF era for screening and for treatment. I have no financial disclosures. I am primarily an adult retina specialist. About maybe 15 to 20% of my practice is pediatric retina. And as Matt mentioned, really there's workforce issues in the United States, and that we really have limits as far as the people that will screen, and even more limitations on people that are willing and trained to treat retinopathy prematurity. But why we really care about prevent this, we want to prevent a stage 5, which is the #1 cause of blindness in children in the United States. So I and my fellow, we cover 6 hospitals. 2 of them are level 4, level 3 regional centers, and 4 other local hospitals. Our ROP team consists of trained nurses who do the imaging and also education for families. There's a pediatric our fellowship program, and we do the screening for these 6 hospitals and also do all treatments. All the infants that meet the screening criteria are first imaged. So we do bedside exams then for all high-risk infants. We perform over 1,500 exams a year. Treatment would involve either anti-VEGF therapy or a laser treatment. We are a regional referral center, and so we do perform pediatric retinal surgical services for retinal detachments and fever and Coats disease and every other disease that a pediatric retinal surgeon will see in our hospitals. So we have a very committed and trained staff, we used the RetCam for about a decade. And then we were fortunate enough to acquire the Phoenix Icon Connect system, which enjoy about it is really it's easy to access, easy to acquire images. It's a very low, the camera is very easy to use. It's very lightweight. And one thing that's very convenient is the software, the Connect system. And so I just kind of wanted to show you kind of just what happens is that we have our trained staff, they acquire the images. Then it gets, again, from my cell phone, I get a little message that says that I have images to read. This is a little screenshot of my cell phone. And then we connect, and then we get the images. Images come, we get some information regarding the baby. This is one that I saw this last week. And this is not a typo. We have a first exam on a 22-week infant born at 500 grams. And so even with looking at these images on your smartphone, on your cell phone, we can see that, you know, this first exam on this 22-week infant, you can see obvious, stage 2 disease. This is the right eye, nasally, temporally, really an obvious demarcation line here between the vascularized and the avascular retina. And so this is a baby that obviously we're going to need to follow very closely. So after a few clicks, then we will generate a report noting the disease. It then gets sent and it's integrated into the EMR. So what's nice about this, it's really done at the convenience of the nurses when they can image, when they have availability. I get an alert. Generally, we try to read within 6 hours. The patient data is all available. Comparison data can be acquired also in this program. We can then, just after a few clicks, can we integrate this into the EMR with the photos, which then provide education for the staff and also for the parents. Any high-risk infant that we identify, we do a bedside exam. All of these high-risk infants that are identified at outside hospitals, they are transferred for treatment. And we do still see some garden variety ROP that we treat with laser, but really what we see now more than anything is this aggressive posterior ROP. Because we're seeing more of these very low birth weight babies, gestational age of 21, 22, 23 weeks. They have a very aggressive zone 1 disease with neovascularization of the iris. They have a very active TVL, and they also then have very high VEGF levels and need, early treatment. And we're treating them within 32, 33, 34 weeks. This is very aggressive disease in which, we've documented these babies going from, stage 1 disease, developing flat neovascularization that can progress to, stage 3 in a week. And they have a very high risk of retinal detachment. These children, thanks to the BROP data, we treat them with anti-VEGF. And what we find is that after treatment, as we see in this, the lower photos, after treatment, the ridge can regress, and then we have continued vascularization. But we've, treated with, anti-VEGF, now what? We really can't inject and then forget about following these babies. We need to continue to monitor them, examine them, and follow them quite closely. Because what we find is really the anti-VEGF can buy us some time, in that there is a very real concern about late reactivation of retinopathy of prematurity, which can occur, several.
I think she had an internet problem.
Issues.
She might be coming. But I think what she said is very important because we were just talking about imaging, but this is very important. Imaging is very important now as we have availability of anti-VEGF treatment, and we have to evaluate periphery of these kids and for a long time. And it's very important to engage the team. So the kids, as Matthew was saying, it's difficult. Parents have to come back, and it's important to have the images to show. What I usually say to my patients is that whenever I don't take a picture, it's just like if you were drawing a picture of someone, if you take a picture, you know what you see, and you can follow it up much better, much more confident. So I'm very looking forward for her presentation about the anti-VEGF.
Andrea, there is also a problem with anti-VEGF that more and more ophthalmologists can do anti-VEGF, but not laser treatment in this patient. So we notice that a lot of ophthalmologists start to do anti-VEGF and ROP, but then they don't follow up as we used to do. So we see some complications because of that, and that is very important to say, I think.
Yeah, we have to, once you inject anti-VEGF, you are committed for a long time. As patients and parents, they have to understand that, because we are a team. It's not only the doctor's responsibility, but once you share the information, it's we are a team, including parents. It's
also
us.
Parents, yeah.
Yes, because they have the responsibility to bring kids back so we can take care of them.
And I think that is important to say that when we choose which treatment we will do to the patient, because if we feel that parents will not follow up the baby, maybe laser is a better option in these families.
Yeah. And do you think, you said other people are doing anti-VEGF, pediatric ophthalmologists?
Yes, I think that since anti-VEGF are now available for ROP, pediatric ophthalmologists start to use it more and more, even those who don't do ROP in general or do not perform laser because they don't have laser or because they don't have experts to do laser. But anti-VEGF, yes, so they start to do more and more. And sometimes we have to say that the follow-up is necessary and it's more complex and it's longer, and sometimes laser is needed anyway.
Yeah, we have to share information. Is that your expertise, Dr. Dogra?
Yeah, I think we have a lot of problems regarding this, because many people, those who are knowing very little about ROP, they have started injecting earlier than indicated, and not telling at all that these children, they need follow-up. And sometimes not only this, they would sort of let them go, and the child is coming back later on with all the problems. So we face a lot of issues. So what Alejandra said and Andrea is talking about, I think we have to have some kind of a very strict protocol. If the parents are not going to bring back the child, that child definitely we're not going to inject. And of course, many of these as same problem with us. I think we have very few people, those who would do good laser. That is a problem probably worldwide, that we don't have that. And anybody can do injection. So they are ready to inject, just pop in the needle and feel happy. So that's a problem. And this problem is to be solved somehow. And we need more regulation regarding that. Because otherwise, if the follow-up is not available, we have seen a lot of these recurrences with very bad detachments happening later on. And then in these cases, you can't even help them much. Perhaps some of them, I don't know if the Polly was going to talk, because they do need quite a number of them additional laser after we have injected them. So that is to be kept in mind, very important, because that's how we're going to look at them and look at if this case is showing some kind of a recurrence or reactivation. At that stage, definitely we need to do laser. Maybe now we do less laser because vessels have grown a little more further. So I think that is what we need to follow at this time, which and not just think that we have done injection and everything is over. That's a problem.
Yeah, before asking Matthew, I would just like to make a quick comment. We have a WhatsApp group in Latin America and in the Americas, and a colleague from the US just asked us about a baby that was presenting endophthalmitis, a baby that was referred to her department, and it was very, it was clearly an endophthalmitis. So we have, it's not only about long-term follow-up, but the short-term complications. And Matthew, what is your experience?
With anti-VEGF?
Yeah.
Yeah, so we've typically been using Lucentis over Avastin. And I'd like others' thoughts, but I've been frequently lasering before they go home. So we'll often inject. They're young. It's difficult to do the laser because maybe they're not dilating well. And so we inject, it goes away, and then the kid's getting close to going home. Maybe there's a little recurrence that you've just been watching, or maybe there isn't recurrence, but my approach has been put in a little maybe zone 3 laser, and at least it makes me feel better. We haven't been getting the late recurrences, but we keep following those kids. I don't know if other thoughts, people just prophylactically laser, but we'll often inject, let them get older. The kids are stable, maybe they're off, they're not intubated anymore. The laser's a lot simpler, the kid's stable, the NICU's not worried about, having to put the kid back to sleep or anything. You can do it just the bedside. So our approach has been with the anti-VEGF is often just put in laser, even if it's going really well. And then often I'll tell the NICU, tell me when you think the kid's going home. And so when they're getting ready to go home, we just talk with the parents and say, we can either watch weekly for months or potentially just put in a little laser, and maybe hopefully the follow-up will be maybe easier.
Yeah, that's a very sensible approach. And we are having problems with Polly's back. Thank you.
I am so sorry. I completely lost my internet. So I actually left my home because I have 4 children that are constantly on their computers, and I came to work for better internet, and that's what happens. So I'm sorry.
Welcome back.
So do you want me to start again?
Yes, yes. Can you?
I'm so sorry. That was ridiculous. All right.
No, it's fine.
It's fine. We were talking.
Okay.
Thanks to your presentation.
Yes.
All right. I'll start from the very beginning. How does that sound? All right. Let me share my screen. All right. So back to the beginning here. So I don't know when I lost you, but so basically
you lost us, Polly, when you started with anti-VEGF injections. Okay. I think because we were discussing this issue and we were all in now. So please continue from that point.
So we're, like I said, we have 6 hospitals to screen. We have, me and our fellow. And so really to do this, we, need to have this efficient, just system for us to be able to do the number of exams, and that we're seeing high risk infants. We're doing over 1,500 exams a year. And the reason that we can do this is just because we, have a just an efficient system, a great team. We have all of our protocols in place, like Matt explained, is that you just really need to have a very good system. You need to have trained people to help you. So we're able to do all this. We also, treat these high risk infants. We, don't see a lot of, garden variety ROP. Because we're seeing all these 22, 23 week infants that are born at, 300, 400 grams, we see a lot of the zone 1 disease. And it's this active, TVL, it's, plus disease that, these are babies that we treat, and primarily by using anti-VEGF. These are really high-risk babies. They progress from stage 1 to stage 3, and you can see it in a week. They have a high risk of retinal detachment. We treat them with anti-VEGF based on the beat ROP data. And just like they see in that clinical trial, once we treat, we have then regression of the ridge progresses into the periphery. But we really can't just inject them and forget about it. Is that these babies have a very, high rate of late reactivation, which can occur between 4 and 5 months after injection. And so we really continue to monitor and examine these babies quite closely. We, are very aware of and have seen babies that have, come to us who are bilaterally detached after anti-VEGF because they were really never followed. Okay. So for example, here's a previous 24-week infant. They had anti-VEGF therapy at 35 weeks. These images are really kind of deceiving in that you can see the original ridge. It looks inactive. They're now post-menstrual age of 50 weeks. These are babies that, because they're in this high-risk window, we take them to the operating room. We use fluorescein and angiography to really identify if the kind of the progression of their vascular development. And this baby, who looked deceivingly inactive by examination, has active NV, and this will progress. This will progress to a retinal attachment without treatment. So the question is, do we re-inject? Do we laser? And we can talk about that further. So we find that really these infants that have had anti-VEGF have some pretty characteristic angiographic findings, in that here is a baby, this is their original ridge, injected with anti-VEGF at 35 weeks. Now 2 months later, can see that there was progression, continued vascularization, but now they're 56 weeks. The vascularization has stopped, and now we have just active neovascularization. Again, post-menstrual age of 60 weeks, these vast areas of avascular retina. And so, that is a concern. We noticed this incomplete regression in some babies where this ridge just never goes away, and they're 56 weeks now. Also, these characteristic just vascular loops that we can see in the periphery. And once you do a fluorescein angiogram, there is really no development. There's no vascularization that goes beyond that loop. And this baby is now 56 weeks. Other babies really, show minimal progression. I mean, you inject them, there's zone 1 disease, you inject them, and really the blood vessels do not continue to progress. And this is an infant that's now post-menstrual age of 60 weeks. Again, 58 week now, had anti-VEGF. You could see where the blood vessels were here at the time of treatment. There's been some vascularization, but really just a lot of avascular retina in the periphery. So our experience is that we looked at our first, 35 babies, severe, low birth weight. And of these babies, about 20% of them would completely vascularize. The other 80% by 60 weeks did not vascularize. 10% had neovascularization, incomplete regression in 5, and then just minimal progression that I showed you about 20% of the time. So really, our standard of care has changed for some of these babies. We inject anti-VEGF for zone 1 disease. This allows foveal development. We allows the macula to develop, but then we follow them, and at some point the vascularization stops. And so if they're not vascularized by this 55 to 60 weeks, often we'll do laser treatment because we've followed these children before where they've had active neovascularization. We re-inject them. We then do another fluorescein angiogram in 2 months. The neovascularization may be gone, but there's been no progression of the vascularization. And then you re-image them 2 months later, and the neovascularization is back. So we do the definitive treatment, which is to laser them. So in this treatment of the avascular peripheral retina is based on some of the data, looking at the cryo-ROP data, and that we have the 20 plus year data for the cryo-ROP. And we know that the babies that did not receive treatment, the ones that did not detach early on, when they look at them 20 years later, half of those eyes detach. They detach because you have these vast areas of avascular retina that are untreated. And so we want to really promote this lifelong stabilization of that abnormal retina and reduce the chances of retinal detachment later on. So way we look at it, APROP is just, more commonly seen. The stakes are very high. These, babies need close monitoring and treatment. We have telemedicine and imaging to be able to really provide the highest quality of care that we can. Anti-VEGF will buy us some time, but we need to do continued exams. We need to potentially, laser and treat them, in the future. So just wanted to thank you. And I'm sorry for my technical difficulties. So.
Thank you, Paul. It was really a pleasure to listen to your talk. So now we have a lot of topics to discuss about. Let's start, for example, with this. Since we are talking about telemedicine, with this avascular retina, and if you have a child which is in a dislocated NICU where there is no chances of laser, let's say, so probably you would advise, according to the pictures, to re-inject, or how do you, in the contents of telemedicine, how do you treat these children, or how do you perform the treatment?
Well, every baby that is high risk that's been identified in the outside hospitals as needing treatment is transferred to our main hospital.
Mm-hmm.
Just because we won't even have people that will screen in these outside hospitals, much less do treatment. So they all have to kind of come to the main regional center for treatment. We keep them and monitor them. In general, they, most of the time, for whatever reason, are not transferred back. They sometimes have other issues, but all of the babies come to the regional center for treatment.
Thank you. There was a YouTube question. It's not directly related to, it is of course to ROP, but not telemedicine. But what is, in your experience, maybe all of the panel, everybody from the panel can answer this. What is the ratio of zone 1 and posterior zone 2 requiring treatment to all requiring treatment? So the posterior ROP, what percentage do you get according to your experience? What do you think, Dr. Dogra? What would be your answer?
I think we have a lot of children, especially in our country, with aggressive posterior ROP and zone 1 ROP, and their number is very high. We had even published last year about the posterior zone 1 ROP in the Canadian Journal. In fact, we started seeing more and more of those also. And so at this time, what is happening is, especially if we talk in our own context, why it is happening is because we still have increased survival of these babies happening in the level 2 NICUs outside, where probably they may not get really that kind of monitoring. Sometimes they receive even 100% oxygen. So they develop a very severe posterior ROP. And this has been experienced also in many other middle-income group countries. And that's how perhaps our rate of zone 1 and posterior zone 2 ROP is very high. So is aggressive posterior ROP. We almost, if we talk of outborn babies which come to us, the majority of them, 60 to 70%, are aggressive posterior ROP.
Wow, this is a huge number. What would you judge this percentage in France, Alejandra? What would you say?
No, it's not the same for us. We don't have a lot of aggressive posterior ROP. I will say that zone 1 and 2 posterior will be about 30% or 35% of all treated ROP.
Thank you. There was a question which was really a smart one, I guess. So if all the worldwide, we don't have possibilities to transfer all the babies. So do you have anywhere, according to telemedicine results, so to our pictures, do you have somewhere neonatologists injecting babies, or is there somewhere in the world anything like that? No, Dr. Dogra, no.
No, not at all. I think that we can't do because they are not trained to do that. And as well, we'll have not only perhaps they may take care of other things, they might injure the lens and they have no idea what is to be done. And so I think we'll land up with more catastrophes. So neonatologists injecting in the eye is going to be a problem. That is what I would say.
I would agree, yes. What do you think, Polly? Your percentage of really aggressive posterior, I got the idea that you get the worst cases.
It is close to 90%. Very rarely do we see a baby that we can just primarily laser. But it's very common.
Really, because it's not the same here. I would be equal to Alejandra, I would say. What about you, Andrea? What is your experience regarding this issue?
Well, the unit I screen is very low, but I can say that in Latin America, it's quite high percentage, just like in India. And I would like just to add something. The third international classification will come up, and the aggressive posterior ROP won't be called that way. It's just aggressive ROP, recognizing that we have this kind of disease in zone 2, posterior zone 2. And that's because we have bigger babies, and as Dr. Dogra said, with varying levels of neonatal care, and we have this presentation quite in high numbers in the region. This is the third epidemic of ROP.
Shall we touch a little bit also the avascular retina remaining after the baby is discharged? What do we do with it? Do you laser like Matt told us, which I also do, I must confess? What do the rest of you do?
The anti-VEGF for sure. If they never had ROP, no, if they just never vascularized. But just to clarify that, I would laser anyone that had injected with avascular retina for sure.
Same for me. I would say I would agree with Matthew that if the retina is going to be avascular and it's not going any further, we laser them all, because it's a problem. Because once the baby has grown very big, then you need to take such a baby to the OR for a general anesthesia. And then it's difficult. I mean, you can't even examine, because sometimes it so happens that the vessels are not growing even after 1 year, 1.5 years, and you get very scary. And that's what we have a very little sort of patience not to laser them.
Yes, it's the same for me. Andrea,
I would like to... Sorry. Go ahead.
Sorry, I wanted to ask a question to all of you. When you perform anti-VEGF injection, do you perform operating room under general anesthesia or in the neonatal units?
Matthew, what you do?
Yeah, so we do often the laser or injection at the bedside. So we'll just have the neonatologist give usually some sedation just to help for the injections, because that'll be quick. But even for the laser, we mostly do it at the bedside.
Same for me.
We
Molly?
are more,
Yeah, at the bedside.
Yeah.
we are
Correct.
doing in the OR because perhaps there are other issues where we may not be having such a environment where we can inject, but we don't give any anesthesia. It is just done very quickly, just a topical anesthesia, inject and out. But it's taken to the OR just from that point of view that you'll be surprised that even in India, most of the anti-VEGF injections, even for the adults and the old people, are also done in the OR because of the similar consideration. So that's why, not with any other consideration.
I agree with you. Andrea?
Yeah, I just said that I do the same as everyone else at the bedside. And I would just like to make a very quick comment on transferring the babies. The way we organize here in Rio, for instance, it's a 6 million city. We organize the ROP team to screen to go to the units. So we rarely transfer the babies. In COVID times, it's very, convenient not bringing external babies to our units. We organize ourselves to go to the units the way we do. It's better for the babies.
Okay, so yes. Andrea, did you want to say something, or shall I comment on our Menti results now, so that you know what public is listening to us? So the first question was, where are you coming from? And there are majority, I would say, more than 40% of our viewers are from Asia, a little bit over 30 from Europe, North America 11, and South America 5%, Middle East 5% as well. Then we have, of course, more female than male participants in pediatric ophthalmology. And then which system are our participants using? Still, the majority is using RedCam, 42%, 5% Phoenix, Forus 11, Panocam 11, and other 32%. So these are the questions. And then we asked, what would you like to improve in telemedicine, your telemedicine ROP setting? Time to train and perform was an answer. Training ophthalmologist, secure digital platform, good trained personnel, cheaper equipment, I agree. Accuracy, software, development of telemedicine, and that's it. Good cameras, okay. Images with smartphones, good. Cheap, cheap is very important. Okay, so these were our Menti questions, and maybe we can then proceed further. So are we, 29 minutes. So we have to finish. We have to wrap up. So, okay, I shouldn't forget our Phoenix sponsor. So thank you once again to Phoenix Technology Group for their support of this webinar. The Phoenix Connect connects to the nursing, ophthalmology, and neonatology teams through one system and facilitates your timely expert screening of patients in any NICU, enabling delivery of the best care. Thank you, Phoenix, for this support. Then, of course, we have to thank our host, Antod. And at the end of this webinar, you are very welcome to watch their video, and also there is a video from Phoenix. So thanks to our admins, Dara, Emma, Camila, and Aquila. Our upcoming webinars, which I will just share, are coming in, sorry. So this was Alejandra, and then these were we, thank you. And then these are our upcoming webinars, which you are all invited to join. Please also join join the WSPOS. Membership is free. And then you can connect through various channels. And David Granant is making an international listserv, so please feel free to contact him. And at the end of our webinar, Andrea will ask everybody a take-home message. Please, Andrea.
Yes, I would like to hear from everyone. Thank you very much first. It was really great to be for me this morning with you guys, but I would like to hear from you after so many interesting presentations. What would be your take-home messages? I will start with you, Polly.
So setting up a program is, very worthwhile. Getting the camera, having the processes, it's surprisingly easy to train people that really even have no experience. I mean, our ROP nurses, they learned going from one camera to the next, and they had it perfected in like a day. And so just being there and training them, you can set up a program, you can have people to help support you. And it's something I think that we just, as people that take care of these babies, just need to promote and continue to do.
Thank you. Alejandra, your take-home message?
I will say just get a camera, whatever one, but get one camera, because I think it changed all the follow-up for these babies, and the prognostic depend of a good screening. So just get a camera, anyone.
Matthew?
Yeah, kind of emphasize what Polly was saying, but I think a key is having a very good protocol. So, what exactly is going to happen? What are the steps? Who's in charge of what is important.
Thank you. Dr. Dogra?
For me, for a long time, I feel timely screening and detection of the treatable stage of the ROP. These are the two things. How we achieve it, whether it is going to be a digital camera or somebody looking at it, this is a big challenge. At least this is the biggest challenge for a country like ours, which has a huge population. So the timely screening and detecting a treatable stage, if that can be done, it will be a biggest service. How we achieve it with a camera or otherwise, I think we have to look at that part very, very seriously.
Mansa, may I summarize this? Because I think it's very important. They all said, Polly said, health team, healthcare team, trained healthcare team. Alejandra mentioned the device, you have the machine. And Matthew and Dr. Dogra, protocol in place, training people. That's the key points of a successful screening and treatment program. It may be different depending on where you are. The babies also present different diseases. Polly is used to see 22, 23. Dr. Dogra and myself, we see bigger babies. But I think what unites us is that we have good protocols in place with good personal training and also having access. If a good camera or if a smartphone, we be able to share the images and improve the ROP care. I think it's amazing. Thank you very much.
Thank you to everybody. It was a great pleasure to having you on this webinar. See you next time. Bye-bye.
Thank you. Bye-bye.
Thank you.
We all know how difficult it can be to diagnose, treat, and manage a condition like glaucoma. As a leading ophthalmic pharmaceutical company, we all know how difficult it can be to diagnose, treat, and manage a condition like glaucoma. As a leading ophthalmic pharmaceutical company, we've been actively involved in cutting-edge research in glaucoma therapies and formulation technologies for over 2 decades now. As part of our commitment towards this cause, we are delighted to announce the launch of our Free Glaucoma Therapy for Life campaign on the occasion of the World Glaucoma Week 2021. As part of this campaign, NTOD will commit to financially support 250 needy patients around the world with their glaucoma medicines for life. We thank the World Glaucoma Association together with glaucoma societies around the world for their support for this cause. This campaign aims not just to support those who are unable to afford their regular glaucoma medicines, but also raise the awareness of glaucoma, which is one of the leading causes of blindness in the world.
Does this ever happen to you? A patient is scheduled for bedside ROP screening. The patient is dilated and ready for the exam, but the ophthalmologist is tied up in the OR or running late with another patient or even stuck in traffic. Or maybe the ophthalmologist is ready to perform the exam, but the patient starts crashing, needing emergency care, or is undergoing another critical procedure. Now there's a way to screen when it's best for the patient's care while also optimizing your time and the ophthalmologist's time. Introducing Phoenix Connect, the leading telemedicine platform for ROP screening. Upload exams with images from any wide-field retinal camera and store them in a HIPAA-compliant cloud. An SMS text message or email alerts the ophthalmologist when the images are ready for review. The ophthalmologist just clicks on the link. The images can be accessed from any place at any time for any device. To complete a review in under 5 minutes with easy-to-use tools. When they're finished, a report will be automatically generated and sent back to your team at the hospital. It's that simple. How do you screen a baby for ROP when you can't be bedside? Introducing Phoenix Connect, the leading telemedicine platform for ROP screening. Upload exams with images from any wide-field retinal camera and store them in a HIPAA-compliant cloud. An SMS text message or email alerts you when the images are ready for your review. Just click on the link. Access the images from any place at any time from any device. When you're finished, a report will be automatically generated and sent back to the hospital. It's that simple.